Thank you, Dr. Wong, for giving me opportunity to discuss telemedicine in our setting here at Kaiser. Um, I'm going to focus my lecture essentially on three problems with diabetic retinopathy, as we know, and how I think telemedicine is a perfect solution and what we are able to implement here in Kaiser. So, diabetic retinopathy, there are three parts to the problem. First thing, we all know it's the number one cause of blindness between 20 to 74-year-old. We all know the risk of blindness decreased by 2/3 if we look at diabetic retinopathy report, 14 from 28% to 12%. But the problem is the traditional screening can only carry 40% of the patients of diabetic retinopathy. And this is based on the National Committee of Quality Assurance. So we really have a problem of a disease which can be treated and we can prevent blindness, but at the same time, the traditional methods are not working out perfect overall in our country. So we also know diabetes is increasing. The prevalence is going to increase from 14% in 2010 to likely 21% in 2050. We know the demand for the screening is going to increase, of course, as diabetes is increasing. So we are expecting diabetic retinopathy to almost triple during this period. So that means from 6.7 million to 19.4 million people are likely to have retinopathy. So now the question is, are we really going to be able to have enough ophthalmologists help out? So ophthalmologist percentage is only changing by 2% during the same period. So we really have almost a deficiency between the demand and supply going on right now. So what is going on right now? So if you look at the present state, we know that 1.5 million cases per year is incidence of diabetes. And if you look at eye care professionals, around 467 medical student match in ophthalmology in 2016. In 2015, 1,557 graduates from optometry schools in the US, including Puerto Rico, started helping to the workforce to take care of diabetic retinopathy. So we need around 2,000 new eye care professionals to screen 1.4 million patients newly diagnosed. On an average, we need around one eye care provider per 700 patients in order to provide good care. So the question is, do we expect these big buildings or these big institutions like, this is our Fontana Medical Center, to be the center of care? Or is it possible to take care over to where the patients are at? As in take the care over to the different clinics we have already established throughout. This is San Bernardino County. We have multiple clinics spread all over the county. Is it possible to spread the care to these multiple locations so that patients don't all need to come to these big institutions of practice? So this is where the big medical centers are for Kaiser, and if you really compared to multiple other locations, you have all these other multiple small locations throughout where we can have patients easy access to their care, whether they have an eye doctor present in that location or not. So how do you end up doing it? This is the workflow we have. So we are trying to take the diabetes care away from where the eye doctors is toward their family medicine practitioner, their internal medicine practitioner, their endocrinologist, which they anyway have to meet to get the care. So let's say the patient has no diabetic retinopathy. We need to take a look at the back of the eye. And I want to make something clear here. We are trying to separate the comprehensive eye examination care in optometry offices from the care for diabetic retinopathy screening. So these patients can be seen in any of the facilities we talked about, and they can have photos done, and those photos can be repeated 1 to 2 years if they have no retinopathy. Let's say they have a minimum retinopathy. So in that case, we should at least repeat the photos once. So this all care is going to be taken care of by family medicine, internal medicine. Let's see now patient has moderate retinopathy. So when do we actually start needing to treat a patient with moderate retinopathy? If they have macular edema center involving. So that can be done in optometry ophthalmology offices by appointments in 2 months. Once they develop severe retinopathy, they're going to have to see, a retina specialist or an ophthalmologist within 2 weeks. Or let's see this patient had inadequate view and we can't do photos, so all of them need to see an optometrist. And this is because we were not able to get a good picture of this patient. That's kind of a workflow we have right now. So the patient will have testing done, and every patient who have diabetes get a trigger in their chart regardless of the healthcare provider they see, and the trigger asks the patient to get the pictures done, and that pictures can be done in any of the facilities they are visiting, and they are all evaluated by our group of retina specialists under whom we have technicians working, and they oversee all these pictures. We also try to detach the ordering system. So the ordering system is automatic. So once the patient is diagnosed to have diabetes, the order is going to be placed centrally for the photos for them. And those orders are going to be placed by essentially their family medicine doctor. Or in the case if they need advanced testing, the order is going to be placed by ophthalmologist who is in charge of eye monitoring program. Going further, the question is, what are the benefits of this separation of diabetic retinopathy screening from comprehensive eye examinations and taking the screening directly to the providers who take care of the patients? It improves the screening rate. It improves the treatment rate because we are able to catch them early and treat them early. Once the patient is educated and they get to know about their diabetes condition, we are able to improve the general diabetes control. Also, if you're treating them early, screening them early, and catching them early, it's quite obvious that we are also going to decrease the vision loss due to diabetes. So improvement of screening rate is up to 90%. Remember, it was 40% based on the national survey we talked about. So how do we validate this clinic care? Well, category 1 patients is just a screening patient in which there is no to minimal retinopathy. And then we have a category 2 in which we have a screening risk stratification based on whether they have a mild, moderate, or severe. Category 3 screening is in which we are also providing treatment, and this is happening when they have a severe NPDR, early PDR, or high-risk diabetic retinopathy, or DME. So these are different levels of clinical validations that American Telemedicine Association have in place for the process of screening methods. So if you look at the Kaiser setting, we are almost reaching level 3 to level 4. The reason we are saying we are reaching level 4 is because we start the treatment for the patients when they start with central involving diabetic retinopathy. So there was a quick summary. I pretty much think we talked about the burden of diabetes and how we really need to rethink how we are managing diabetes. There's this popular quote from Charles Darwin. It's in the long history of humankind, and of course animal kind included, those who learn to collaborate and improvise most effectively have prevailed. So I think this is an opportunity for us to really critically think about how we are providing diabetes care to our patients or diabetes eye care of patients. And I believe the method of telemedicine and screening at the point of care, convenient to the patient, is the way to do it. Thanks again. We'll leave my contact information with Dr. Wong, and please reach out to me if you have any questions. Thank you.